Appreciate you guys coming. Thank you.
Thanks, guys. So thanks again for coming. I'm just going to do a brief overview, and the majority of really the learning piece will take place in the lab. I skipped over, obviously a lot of the anatomy pieces, but we'll talk about Maya real quick, ultrasound, how we integrated with Segway, and then a few of the applications, but just a brief overview on techniques, and we'll really get to that when we're in the lab. So Trice started out as an in-office diagnostic company, and we make a disposable, sterile, single-use camera. And so it's a 14-gauge, all-inclusive needle that houses a camera inside, so that you can percutaneously go into the joint, retract your needle, view, diagnose, and inject through this port here, or aspirate. So we really started out as, if you see this down here, being an alternative to an MRI. And patient comes in, they see, their doctor, they prescribe an MRI, they go out, they come back, they see them again for the consult, and then they're scheduled, if surgical intervention is needed. So, we thought on that first office visit, or even on the second, if you wanted to schedule that we could shorten the care algorithm, bring a profit center to the offices, and actually we've done some studies, which I'll show in a minute, on the cost effectiveness in comparison to the MRI. So it's a 120-degree field of view. How everyone familiar with arthroscopy to a degree? Yeah, so it is a 0 degree. So as opposed to looking at your traditional 30, we're straight ahead, but we do have a bigger sort of a fisheye field of view. We'll have a 30 degree down the road. That's in the works. But everything's digital, and it works on a tablet. It is a Surface tablet, so I'll show you that in the lab. And we're using that diagnostically. We also use it in the procedure room for some mini procedures. It's become a pretty big tool for injections, whether that's cortisone and they need to get more information. You're an in-between patient with arthritis and they're not sure what delineation you need to go to. It's a great tool where you can go in, diagnose, show the patient firsthand, and then inject your whatever biologic of choice. And we're using the existing diagnostic CPTs. So, quick overview on that. So really why we developed this was the value to the 3 different arms of the system, the payers, meaning that it is an immediate answer, it shortens the algorithm, especially in the workers' comp field, and it's cheaper than the MRI in most scenarios. Obviously, MRI prices are wildly varied. For the patients, it's quicker, it's a little more definitive. We've got some studies coming out of MGH in the shoulder around comparisons to MRI, and it's been a good tool to rule in certain pathologies. And then obviously for the practitioners where, regardless of MRI ownership, that they have the ability to dictate care from the diagnostic standpoint in their office, but they can also bill for that. One study we did looking at the cost of MRIs in comparison to the CPT for diagnostic arthroscopy in the knee and the shoulder, and we saw around $500 savings private and around $1,000 commercial or hospital-based. So again, we know that MRI prices are wildly ranging. So techniques is pretty simple. Procedures probably last 5 to 10 minutes. Obviously, as you get more facile with the device, the 0 degree of the numbing protocol, it'll take shorter. But we're identifying the patient, finding out which indications you feel suitable, quick skin prep. We're localizing the skin with lidocaine, some use a little epi, and then we're re-cleaning the joint, and we're going in with the camera, retracting the needle back, so you don't have to take the device out. There's no in and out with the trocar. It's all a single-use integrated system. And then we're adding some saline into the joint to see the tissue move. We're aspirating that out at the end, and patients walking away usually with a Band-Aid. So. Within that, we wanted to build out the capabilities of our tablet for more value, so we did add ultrasound to the system. And we talked to a lot of people around why, and whether you need ultrasound or not for diagnostics or for injections. It seems like a lot of the patients have read about ultrasound, and they seem that whether they're getting an injection or someone's diagnosing them, that they want to see someone using ultrasound, whether it helps you or not. A lot of practitioners have told me, I don't need it, but my patients ask for it because the person down the street offers it, so they've moved to using it as a value add to their patient. It's also Another reimbursable aspect has been a little bit reduced over the years with some, with more and more use of that. But our system competes with all the portable systems, 15 megahertz. I don't know if you guys know much about ultrasound, but I can talk to you a little bit more about that in the lab. We do have a curved and a linear transducer, so you can go shallow to deep within your tissue. It can be used in addition to the Maya if you wanted to guide that with an ultrasound, but most of our users use it for injections and diagnostics. It is portable and it has Doppler. So, and I still think a big aspect of ultrasound is the injections and also marketing that in the office. And so really what Segway did, what Trice did with Segway was we brought the two families together, and we wanted to take the diagnostic capabilities to procedural, so that one, you could diagnose, but you could also treat, and that's where we started within the carpal tunnel, cubital, plantar fascia, gastroc. So eliminating the need to have a full video tower, moving or improving efficiency by doing procedures in the procedure room as opposed to the operating room, and potentially even moving these into the office space, which we've already started to do. And our next system will integrate the reusable tray and the disposable aspects, so that you could do these with a peel pack, opening up instruments, using the camera, and doing everything in your office. Any questions to that yet? Perfect. So we'll touch quickly on plantar fascia as the endoscopic system. It is a single portal. We're using a standard scope, 4 millimeter, or your 2.7, and you can also use this. Today you can use this. It's not quite to where we will be in a few months with the technology, because we'll have a married set that fits together perfectly with this, and it'll be angled a little bit more, but you can use this today. We have people do this today. It's a minimal incision, less tissue damage, and we find that the patients are able to walk around the next day. We do have different guides, more for the carpal, but you can also use those preference on where you want the camera to sit within the guides. And what you'll see in the lab is the Segway guide. If you're familiar with endoscopic systems that are out there, it really opens up the field of view as opposed to a tall guide. It's a wider guide, so it keeps the tissue out of the scope's view, so that you view all of your cut. You can go in, you can go out. We have probes and rasps to make sure that everything has been finalized and that we haven't missed any fibers in that release. So the technique, I'll skip over this and we can really dive into it. But really, I bolded out your portal placement, and most of the time we do 4 finger breaths from the posterior aspect of the heel and 2 from the plantar aspect of the bottom of the foot. So I'll show you these on the cadavers a little easier. But we're making a small incision. We're going superficial or posterior to the fascial band, and we're coming in there with the camera. We're probing and rasping to removing synovium and fat, and then we're viewing our release. We can also probe to get that 1/3 band, the medial 1/3 band, and then we're coming in with a retrograde knife and cutting that tissue. And when we're done, we can go back in, validate the cut with our camera, keeping that wide field of view, and probing with the probe. Within the gastroc, really addressing equinus and adding flexion within the movements. I won't go into this. Would probably work. Do you guys have any preference on what you do today? The Bauman and the Strayer. We'll probably work more on the Strayer, which is an inferior, but we're making that just distal to the medial head of the gastroc. I think the biggest applications here are that with the guide we can avoid injury to the sternal nerve, and all do this all through around a 3 to 5 centimeter incision endoscopically. Technique on that. Here's the Strayer, which we can skip. I'll help you mark out portal placements in the lab. And then I do have a video. If it plays, that'll be another question. And I think the audio wasn't working earlier, but this will just walk you through the gastroc. The plantar fascia is a little more self-explanatory. But you can see here, he's going in. And those are the different guide sizes. So we have a different channel where the camera stays away from where your blade is so that you don't run into having any scissoring of your instruments. And it also allows you to keep that field of view open during your cut and after your cut. I think with the gastroc too, if you do some dorsiflexion, you can really see the aponeurosis and the fibers moving, and that's a good test to make sure that you're in the right plane. And that's it. Do I have any questions from you guys, or we can really get into it in the lab if you